This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everybody, and thank you for joining us for our HealthyU webinar series. Today's topic is about cardiovascular health. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted. Once the presentation concludes, your questions will remain anonymous. Today's presenter is Dr. Gruberg, a native of Bolivia. Dr. Gruberg graduated from the School of Medicine at the University of San Simon. At 25 years old, he immigrated to Israel, where he worked for 20 years, completing a fellowship in internal medicine and cardiovascular diseases, working at hospitals and teaching at the Sackler School of Medicine of Tel Aviv University. During this time period, he took off to do research as a Fogarty Fellow at National Institutes of Health in Bethesda, Maryland, as part of the Humane Genome Project. He later completed a fellowship in interventional cardiology at the Washington Hospital Center in Washington, D.C., where he later became the director of clinical pharmaceutical trials. Dr. Gruberg, the floor is all yours to present.
Thank you so much, and thanks for joining me. Can you see my screen?
I just see you.
Okay, 1 second. Share screen. Oh, it's not letting me share my screen for some reason.
No problem.
You need to let me share it.
Dr. Gruberg, I'll share the presentation, and then you'll just have to let me know when to go to the next slide.
Okay. All right, let's get started then. All right, let's go. Excellent. So I will be talking a little bit about cardiovascular diseases today. And like Jonathan just said, if you have any questions, I'll try to do my best to answer them at the end of the presentation. So we will be talking mostly about heart disease and how it affects us, and a little bit about some of the risk factors that lead to heart disease. Talking a little bit about COVID, of course, we cannot talk about heart disease without starting and talking a little bit about COVID. Being this a extremely deadly disease that we have encountered in the last 2-3 years, which was unprecedented in the last 100 years. Next slide, please. So if we look at the cases of COVID, here is a chart of all the cases, new cases that were reported of COVID-19 since January 2020, and we can go all the way until last week, and we can see the spikes of cases that we encountered during this pandemic. In the purple line, you can see that's the state of California. New York City and the state of New York are buried in there with the green and the red lines, and you can see the scale is for 100,000. The first bar that you see at the bottom is 100,000 cases diagnosed every week. And we can see that in December of last year, 1 year ago, we had a huge spike where almost 1 million cases were diagnosed every week. And next slide, please. And like I try to stress all the time, this was a very deadly disease. A lot of people have become very skeptical, but I think if you look at this chart, you can see that this is not a joke. And we can see that these are the total mortality, all the people that died in the United States since the start of COVID-19 at the beginning of January of 2020. And we can see that by November 9th of this year, we have surpassed 1 million deaths of this deadly disease. So this is definitely nothing to, joke about it. And I always stress to my patients to do the best they can to be vaccinated and to prevent having this disease, because we know that sometimes the outcome of this disease is not so simple. Next slide, please. But talking about cardiovascular diseases, and I'll put this in the context of COVID in a minute, we can see that heart disease was one of the most prevalent causes of dying in the United States, in the whole world, in the 1960s, 1970s, and that's when we became aware of the danger of cigarette smoking, of hyperlipidemia, diabetes, and all the risk factors. And we started acting on them, and obviously mortality from heart disease started dropping in the years 1990s to the 2010, 2014. There was a steady decrease in the incidence of mortality from heart disease. But unfortunately, in 1914, 1913, we started to see a rise again in mortality from cardiovascular diseases. Compare this to cancer, we can see that cancer deaths have tripled since 1950, and they steadily continue to climb, despite all the advances that we have made in the treatment and in the management of cancer in the last couple of years. But as we live longer, the chances of having cancer increases, and the chances of dying of cancer also increases over time. Next slide, please. So cardiovascular disease, heart and vessel strokes account for the #1 killer in the world. More than 18 million people die every single year from cardiovascular disease, and this accounts for 33% of all the mortality in the whole world. More than 75% of all these mortalities take place in low and middle income countries. And if you look at the bottom of the chart, you can see the number of cases. Like I said before, 18.6 million people die every year of cancer, cardiovascular diseases, and compared to cancer, where we have 10 million people that die from cancer, respiratory diseases, HIV. And that gives you a proportion of the high burden that these cardiovascular diseases play in our society. Some of the common risk factors for cardiovascular disease are the well-known players, as always: high blood pressure, high cholesterol, overweight and obesity, air pollution, inactivity, sedentarism, when we eat unhealthy food, diabetes, of course, smoking cigarettes, chronic kidney disease, and alcohol in high levels. So all of these are what we call the risk factors for cardiovascular disease. And I will be talking a little bit more about that in the next slide. Next, please. Like I said before, I would like to try to put this in the context of COVID disease. And here we see the mortality every week in the United States for heart disease in the purple. Can you see my cursor? Probably you cannot see my cursor also. But on the purple line, you can see the mortality for cardiovascular diseases that increases at the end of the year. When we have the cold weather, there's a higher increase of patients getting sicker and then dying, and it goes up and down, but it's a pretty steady curve during the last 5 years. And in the lower blue bar, you can see mortality from cancer, and at the very bottom, you have mortality from influenza and pneumonia. And here in the red one at the right part, you have that spike in mortalities that we saw when COVID-19 hit us in January of 2020. And just to put it in context for all the mortality, we see that the mortality was higher than heart disease, cancer, or influenza. I know that some people thought this was like just a strong flu. Obviously, this graph shows you that this was nothing like a flu. It's having so many people dying from this disease. But we can see that the mortality for heart disease is out there, and that's where we're going to try to talk about it today. Next slide, please. Like I said before, in the 1950s, 60s, we became aware of the risk factors that cause cardiovascular disease. We can see in blue here, as soon as we realize we start curving on those risk factors, we became more stricter on smoking and diet, diabetes, and mortality for men started declining. Unfortunately, we didn't do enough for the women. And we can see that the mortality from cardiovascular diseases for women was very, very steady and was not changing and actually mortality for men, which is in the blue line, went down, and mortality for female patients stayed at the same level and became higher than compared to men. Then in the late 1990s, 2000, and the year 2000, we started making significant changes, trying to understand heart disease in women. And then as soon as we started treating this, mortality for female patients also went down, and they kind of equilibrated, and right now they're about the same level. So sometimes we think that cardiovascular disease do not affect women. It actually does. It is different from the one we see in male patients, and it's there, and it is also very dangerous, and therefore we need to be careful and take care of it. Next one, please. So this is some of the facts for heart disease in the United States. You can see on the right a map on the United States. The darker the red color, of course, the higher the prevalence of these disease in these areas, related to a number of factors, socioeconomical factors, diet, and habits. And we can see that there's a cluster of cardiovascular disease in the south, and it's significantly lower in the more in the larger cities. We can say that one person dies from heart disease every 36 seconds in the United States. So probably by the end of my talk, unfortunately, 120 people will have died from cardiovascular disease in the United States. Like I said before, about 655,000 Americans will die from heart disease every single year, and it accounts for 1 on every 4 deaths. The cost of our cardiovascular disease is a staggering $219 billion every year, and this is for 2014, 2015, and I'm sure that the number now is significantly higher. Next one, please. Talking a little bit about the heart. So as we know, the heart is located in the middle of the chest, and it goes from top to bottom, from back to front, and from right to left. And the heart is just a muscle. And like any other type of muscle needs blood supply to be able to function properly. So the heart gets blood supply for the heart itself from what we call the coronary arteries. There are mainly 3 coronary arteries, one that goes to the right and to the bottom of the heart. The main artery, which is the left coronary artery, will split into 2 big arteries, one going to the front of the heart, which is the most important. A lot of people like to say the word widowmaker. Yes, this is the famous widowmaker. The artery goes to the front of the heart, which is the most important, the bigger one. It supplies the biggest area of muscle of the heart, and that's why if you have a heart attack on this area, on this artery, it can be very dangerous. And then there's the artery that goes around the left part of the heart, which is called the circumflex artery. So basically 3 arteries provide the blood supply to the muscle of the heart so it can function, it can squeeze like it should, and therefore pumping blood to the rest of the body so we can all function properly. Next one, please. So like I said, we're going to talk a little bit about the coronaries. These are like little tubes. What they do is they transport the blood to the muscle of the heart, like I said before. So it is like a pipe, and like any pipe, it has to be cleaned so the blood can flow through it very easily. Unfortunately, as we get a little older, as we age, there is a narrowing of these coronary arteries, and it is usually caused by the growth of this cholesterol plaque inside the vessel, and slowly that is going to squeeze the artery and make it more narrow, and it will prevent the normal blood flow to the muscle of the heart. And that is one of the most important factors for having a heart attack or having angina or having a cardiomyopathy at the end of the day. Next one. Obviously, if we have a narrowing in one of the arteries of the heart, so the muscle of the heart does not get enough blood supply when it needs it. If it's not a very significant narrowing, it might be that we get chest pain. That means there is not enough blood, there's not enough oxygen getting to the muscle of the heart. And that at the beginning can be when we do something stressful. something that will require from the heart a little bit more blood, more oxygen, such as climbing stairs, walking fast, doing strenuous activities, then we can realize that then is when we get the chest pain or the chest pressure or any type of symptoms. And when we're resting, that goes away. As time progresses and as the plaque progresses, then we can start developing that pain at rest, and eventually that can lead to a heart attack, unfortunately. Next one. So trying to see the arteries of the heart is very simple. We do it through a cardiac catheterization, what it's called. In the past, we used to access the arteries of the heart going from the groin. Now we do it most frequently going from the wrist, right wrist. We go to with little tubes all the way to the heart. Once we're in the heart, we inject contrast that we can see in a fluoroscopy screen, and we can see if there is any significant blockages in the arteries of the heart. We can see if plaque has developed enough to block the normal blood flow, and hopefully we can treat these blockages in a number of ways. Next one. So this is a cartoon that depicts the coronary artery with a little plaque on the left, you see, and we put a little wire, then we put a balloon with a stent. We open the balloon and we leave a little stent, which is just like you can see on the right screen. It's just like a little tube made out of metal. It very much resembles those little springs that we can see in the pens. They're about the same size. They are very, very similar. But what it does, it actually scaffolds the artery from the inside, opening the way and squeezing the plaque to the sides of the artery so that the blood flow can be normal to the muscle of the heart once again. Like I said before, we go from the wrist. We can put one of those little devices inside the coronary arteries, which has become a very simple procedure nowadays. It's a 1-hour procedure. Patients, if it's a low-risk procedure, patients can go home in 3 hours, and they can virtually walk out of the cath lab because all they have is a little Band-Aid at the level of the wrist. Next one. So this is a angiogram of a patient that presented with a heart attack. And you can see this is what we call the right artery. Like I said before, the heart gets blood for the muscle of the heart from 3 arteries. One goes to the right and 2 will go to the left side of the heart. And we can see that the one that is going to the right part of the heart is blocked in the middle part of it. The contrast just stops at the middle part of the artery, as you can clearly see. Next one, please. So this is, here you can see there's a little wire that is going all the way around the artery, and there we have a little balloon that we have inflated to open this blockage. Next one, please. Can you see if it plays? Can you click it to see if it plays? There we go. Now you can see the whole artery. Now you can compare that artery to the beginning of it. You can see that the blood is flowing all the way around the heart, going all the way to the bottom of the heart. So as you can see in the first slide that I showed, the artery was completely closed. That's what causes a heart attack. Like I said before, we go from the wrist, we put these little balloons and stents, and we open the blockage, restoring the blood flow to the bottom of the heart, to the right part and to the bottom of the heart, and averting some of the consequences of having a heart attack. Next one, please. This is the way it looks after we do the procedure. Like I said before, a very tiny needle that goes through the wrist. At the end of the procedure, we take this needle out and we leave this little device that provides some pressure on your wrist for 3 hours. And patient is sitting comfortable, watching some TV for 2-3 hours in one of the radial bays, and then they can go home, walk home, and the procedure is done. Next one, please. So what we talk about, this is what I call the plumbing of the heart. The heart is, we have the 3 arteries. It's just pipes that provide blood to the muscle of the heart, just like pipes provide water to the house. So that's one part of the equation in the heart. Next one. And the other part is, of course, the electrical part of the house or the electrical part of the heart. So the heart also has an electrical portion, and it's actually what gets the muscle moving or squeezing. Next one, please. So the heart has a very intricate system and complicated system of electricity that moves around the heart, and that is what actually starts and creates the squeezing of the heart, or what we call the contraction of the heart. The heart is composed of 4 big chambers where the blood comes in, goes out and goes to the lungs, gets oxygen, goes back to the heart, and then gets pumped to the rest of the body. So all these muscle, like I said before, needs oxygen, but it also needs an electrical current to start the process of the contraction. And this is something that we easily record in the electrocardiogram. So when we go to a doctor and they do an electrocardiogram, all that they are looking at is how is the electricity moving around the heart, where it's starting and how it's moving through all the chambers of the heart. And that can provide us very important information about the health of the muscle of the heart, and also about the health of the electrical system of the heart. On the right part, you can see a series of tubes that are inserted inside the heart. So in some cases, we need to make some very sophisticated measurements of the electricity that is moving around inside the heart, and try to determine if this is one of the problems that needs to be solved or fixed inside the heart. And nowadays we can do that also with the accessing the heart from the groin and doing a series of electrical procedures inside the heart. Next, please. One of the most common things that probably everybody has heard is people that need pacemakers. And that is when the heart, for some reason, doesn't provide adequate rhythm to the heart for a number of reasons. That can be too slow, it can be too fast, or it can even stop. And what we do is we put a little pacemaker on the upper part of the chest, and it has 2 electrical leads that will go inside the heart, and they will provide the current or the electricity to the muscle of the heart, so it can get started and can continue working like it should. This is probably the picture in the middle is about the size of the pacemaker. Currently, pacemakers have become very, very small, extremely sophisticated. They can provide us a number of information about how the heart is working, how it's what it's doing, what it's not doing. And now we have, if you look at the right side of the screen, there are pacemakers that get implanted directly inside the muscle of the heart. There's nothing, there's no cables, everything is done inside the heart, and they provide the electricity from inside the heart. So it has its advantages because it doesn't have any type of wires or anything like that. And that's where science is moving, to have little pacemakers that can provide the electricity to the heart in a very simple but sophisticated manner. Next one. Like I said before, sir, there are some people that have a series of arrhythmias. Atrial fibrillation is one of the most common arrhythmias that we see. As we get older, the chance of developing atrial fibrillation increases with age. About 25%, 1 out of 4 people that are above the age of 70 will have atrial fibrillation. All that it means is that the upper chambers of the heart are not squeezing like they should, and therefore they're not providing a very regular rhythm to the heart, and it becomes irregular. The most concerning issue about atrial fibrillation, of course, is the upper chambers of the heart are not squeezing like they should, and therefore a clot can form there. And this clot can move inside the heart and eventually get dislodged and fly out and go into the brain, causing a stroke, which is obviously a devastating consequence of atrial fibrillation. Atrial fibrillation, therefore, is treated mainly with blood thinners, anticoagulants, such as warfarin, such as Xarelto, Eliquis. There's a number of medications that have come up in the last 10 years that provide treatment, trying to prevent a clot forming inside the heart, and that can cause a stroke in the future. Nowadays, we can go and we can cure atrial fibrillation. Like I said before, we go inside the heart. As you can see on this cartoon on the left side of your screen. We go inside the heart, we go into the upper chambers of the heart, and we do some what we call ablations there, and that can cure atrial fibrillation, so there is no need for taking any more medications in the future. This is a very sophisticated procedure, but it's done more and more routinely to all type of patients. Next one. This is just a depiction of coronary artery bypass graft surgery or bypass surgery. Obviously, some patients that have significant disease in the arteries of the heart that we cannot treat with stents. Sometimes there is such diffuse disease that stents will not be enough to treat the extent of the disease, or sometimes this disease is located in very dangerous locations, and therefore we have to go and do what is called a bypass surgery. And all what it does, it bypasses the blockages and provides blood to the muscle of the heart by putting these other arteries or veins that will bypass the blockage and provide blood to the muscle of the heart. We cannot do that procedure at Mather, and we transfer our patients for those procedures to one of the adjacent hospitals to Mather, such as South Shore University Hospital or other hospitals that are in Long Island. Next one. So like I said before, most of our patients will, if they need more advanced treatment, will be transferred to South Shore University Hospital, which was named in the past Southside University Hospital. And the cardiac surgery program at South Shore University Hospital has been named one of the top 50 best hospitals for cardiac surgery in the United States year after year. The level of experience and sophistication of our surgeons at South Shore University Hospital is just amazing, and we're lucky to have such a hospital so close to Mather Hospital in Long Island. Next one. Talking a little bit about the local statistics on Long Island. About 8,600 Long Island residents will die from heart disease every single year, and about 1,000 patients will die from either a stroke each year. Like I said before, atrial fibrillation is one of the risk factors for stroke, and obviously it has devastating consequences for the patient. Like I said before, women are not exempt from these diseases, and therefore they should be taken care of appropriately. Next one, please. All right, talking a little bit about prevention, we always need to go to the basics, and prevention is one of the key things that we have to do to prevent cardiovascular diseases. This was what was called the Life Simple 7 in the past. This is the 7 things we needed to do to have a healthy cardiovascular system. It was diet, weight, exercise, no smoking, taking care of our blood pressure, making sure that our lipids or cholesterol levels are adequate, and of course, taking care of diabetes. The next slide. Nowadays, since 2022, now we call this Life Essential 8, and we have added one more thing to this list, and this is a good and healthy sleep on top of all those 7 factors that prevent cardiovascular disease, like I said before. Next one. So talking a little bit about diet, this is a slide that shows what we should be eating. This is, next one, the Mediterranean diet. So I see patients every day, and every day I get asked what is the best diet to have. There's a lot of options out there regarding what is diets. You know, we've heard about all the Ornish diet, we'd have the keto diet, the Atkins diet, so many diets, and they are all good, but for cardiovascular disease prevention, the Mediterranean diet is the diet that I recommend to my patients, is the one that I use on myself. I do as I teach. And therefore, it is a diet that is based on whole grains, legumes, fruits, vegetables, healthy fats, herbs and spices, physical activity. We have to have fish in our diet, and we recommend to have it at least 2-3 times a week to have fish. A lot of nuts are very important because they are very rich in omega-3 fats, and trying to avoid the meats, the red meat and the sweets, the cheeses, things like that. My patients always ask me, should I avoid that completely? And I don't agree with that. It is very hard to impose a very, very strict diet where we say you shouldn't have anything like, no sweets, no red meats, no nothing, no pizza or things like that. So I tell my patients, you can have that, but not every day, definitely not every week. And when you have it, just have small portions. The size of the portions is crucial for all this. And if you want red meat, I can understand that. I'm from South America. We grow up eating red meat. I don't know if it's healthy or unhealthy, but it's something that I grew up. I enjoy it. So I'll have a piece of red meat every 3-4 weeks, and I'll have a very small steak, and that's all it takes. But the majority of the diet has to be based on fruits and legumes and grains. Next one. So weight, this is a very big problem in the United States, in the Western civilization. About 75% of the people nowadays are considered to be obese or overweight. Very few patients are now coming and they are at the right weight for their height and age. And this is something we measure with the BMI, the body mass index, which is a calculation between height and weight. So we know that to have a appropriate BMI, it should be below 25. It is very easy to calculate nowadays with a cell phone. You go in the internet, you put BMI calculator and you get your BMI, and that gives you an idea where you stand. And we try to be below 25, like I said before. Unfortunately, a lot of our people are not there. They're overweight, they're obese, and it's very, very hard to lose weight. It is not a very easy task, and I deal with it with my patients every single day. So there are a couple of things that are easy to say, not so easy to do, but the main things to do is to control the size of the portions. In the United States, the portions that we eat are very big, they're large. We eat as much as we can. Whatever we cannot finish, we put it in a little bag and we take it home. But controlling that size of those portions becomes crucial to lose some weight. We have to be active. There's no other way. You have to burn calories, and we have to just get rid of that excess of calories. So it's a very simple math, right? I mean, you are eating too many calories. The body says we have too many calories. We'll put it in the pantry and it will store it in your body as fat. When it doesn't know, maybe for times when there's not enough food, but then definitely will store it. It will not get rid of it. So calories in, calories out, simple math. And in order to lose weight, you have to burn more calories that you're eating, which is not so simple. But we have to eat eat smartly, and we have to be very active to be able to burn those calories. Next one. This is something, like I said before, we have added in 2022, the sleeping, right? The eating on top of every healthy aspect of our life. Sleeping has become very important. It is not so easy anymore to sleep well. And there are a lot of reasons why we're not sleeping so well. So one of the most important factors, it turns out, is the use of our cell phones, right? Cell phones. We have it in our nightstand. They are very close to us. We're always looking at them. And this is one of the most important factors that we're not getting adequate sleep at night. If we don't sleep right at night, that can have an impact on cardiovascular disease. It can have an impact on our cognitive thinking. It can lead to a cognitive decline, dementia, depression, elevated blood pressure, elevated sugar levels, elevated cholesterol, and over time to obesity. So there are some tips here on the right, tips for success about your cell phones. Do not charge your cell phone close to you. You have to dim the screen so it's not bothering you, so it's not interfering with your sleep. You can set the alarm, so you have an alarm to go to sleep, you have an alarm to wake up, and you have to lock your phone so people don't start calling you in the middle of the night. So just lock it, and you can block it. So those are very important things that you should be thinking about doing with your cell phone, so it doesn't interfere with your nightly sleep. Next one. Blood pressure, we have become very strict with blood pressure. The new guidelines for the management of hypertension and high blood pressure have become very stern, and now patients that have a blood pressure that is above 120 and the diastolic, or the lower one, above 80, they are already classified as having elevated blood pressure. Patients that have 130, above 130 and above 80 to 89 have high blood pressure or hypertension stage 1, 140 or higher, over 90, what we used to call in the past hypertension. That's where we started counting as having hypertension. Now it's called high blood pressure stage 2, and anybody that has higher than that is already very high blood pressure. Obviously, we want to treat the hypertension. We know it is what it's called the silent killer. We need to treat it. We don't feel that our blood pressure is high. Some people complain that they have headaches or whatever, but that is only maybe when the blood pressure is way too high. So in order to control the blood pressure, we need to eat healthy. We need to be active, exercising. You need to lose weight. Definitely no smoking. There's absolutely no excuse to be smoking in this day and age. And we have to sleep well, like I said before, between 7 and 9 hours of sleep every night in order to lower our blood pressure. Next one. So I will finish with that, talking a little bit about Mather, one of the best hospitals in our region. Next one. And obviously, I don't need to say very much about Mather. Probably a lot of people you know what Mather is known for, amazing care. It's been in the area for a long time, taking care of our community. And now we have a brand new cath lab that we opened in May of last year. And we are able to do these procedures, not only the coronary procedures, we can do the electrophysiological procedures for the electricity of the heart, and we can take care of your heart at Mather without needing to go to other institutions. With that, I will stop, and if you have any questions for me, please feel free to write them out.
Thank you, Dr. Gruberg. And yes, if anybody has any questions, you can put them in the Q&A feature at the bottom of the screen. All questions are anonymous to protect your privacy. Dr. Gruber, we'll give it a few moments, see if anybody has any questions.
Okay, sounds good.
All right, so it doesn't look like anybody has any questions, but if anybody does think of anything, oh, here we go. Now we see a few coming in. Can you see those, Dr. Gruberg?
Yeah, okay. Okay, so there's a question says about the dairy. I eat yogurt daily. Should I limit? So yogurts, current yogurts are fat-free, and they are very good. I think they're very healthy. They have it's probiotics. The only problem with yogurt, you need to be a little careful. It has a lot of sugar. They are really good, but in order to make it tasty, they have added sugar. So it might be zero fat. When you look at it, it says 0 fat, but it might have like 15 grams of sugar. And obviously sugar is not very good for us. Carbs are not ideal, because if we don't burn those carbs, the body goes and stores them as fat, and that is definitely something we don't want. So just be careful with that, with those yogurts. The next question says, what does it feel like if you have a heart problem? There, depends what, right? Obviously, heart disease can manifest itself in many ways. If you have coronary artery disease, you may develop chest pain, chest pressure, difficulty breathing, tiredness when you're walking, shortness of breath when climbing stairs. There's a lot of things that can come as heart disease. Obviously, going to a primary care physician, having regular checkups, electrocardiograms, checkups, looking if the blood pressure is under control, looking for risk factors such as diabetes, pre-diabetes, looking at lipid levels to see if you have, high cholesterol, all these things. can point us in the direction of having a problem. If you have diabetes, full-blown diabetes, of course, you can have what we call silent heart disease, have absolutely no symptoms, as diabetes will interfere with sensation. It affects the nerves. It affects the nerves of the heart. So you might have heart disease and you may not be aware of it. So if you have all these, any of these risk factors, you should be following with a cardiologist. What prevents bundle branch block from progressing? Avoidance. Okay, so the question is about bundle branch block. Like I said before, the heart has an electrical system that starts at the top of the heart and then it spreads into the different chambers of the heart. The electricity just moves very fast and it goes around the heart. So this electric wave is going to cause the contraction of the heart. Sometimes we have one of the branches of that conduct the electricity around the heart gets blocked for a number of reasons, and the electricity has to move in a different manner around the heart, and it can do it so very easily. And when you do an electrocardiogram, you can see that you have a block in one of the electrical branches of the heart, and it's not dangerous per se. Sometimes this can progress to all the branches of the electrical system, and that's when it can get a little complicated, because at some point the heart rate can slow too much, and that can cause people to faint or to be very weak, and that's when we need to put a pacemaker. There's nothing to progress. This is the electrical portion of the heart can deteriorate without us doing very much about it, unfortunately, and there's nothing to prevent it. Sometimes when we have a heart attack, that can itself affect the nerves of the heart, and that can cause also a bundle branch block. How do you determine whether it's your heart, acid reflux, when you feel something in the middle of the chest? Good question. Sometimes we cannot differentiate between reflux and heart attacks, especially in women. Women, like I said before, have a little different presentation when they have angina or a heart attack. It might come as just some nausea, some reflux, some what they call gastritis, and it can be a little different. So we need to be very careful. If you have reflux, usually it's after eating meals, and it goes away, by having some antacid, and that will take care of it. But if it happens when you're walking, when you're climbing stairs, doing some strenuous activities, then maybe it is not acid reflux, and it should be seen by your doctor. A primary care physician should be able to start a evaluation of this acid reflux and see if this is something that may need to be escalated to a cardiologist. The next question, a couple of recent articles in Consumer Reports indicate that cheese is not necessarily bad for heart health and that it might be beneficial. This is true also for cardio artery health. Yeah, as we know more and more about the heart, there are things that change. Obviously, cheese in large amounts is not recommended. There are some types of cheeses that can be healthy, but some others that are not. So I would definitely check into that. I'm not aware of this consumer report that you are stating. I haven't seen it, but it might be interesting. I think anything that needs to be done, it should be done in moderation. And I think that's the key word. Having some cheese is okay, but always in moderation. This is a question, says, my husband has a slight dilation of the ascending aorta. It hasn't changed in 10 years. Should he be worried about exercising? Good question. So a dilation of the ascending aorta is what we call an aneurysm, an aortic aneurysm, and it has to be followed up very, very closely. I ask for my patients to have a very simple test every year, which is a chest CT. It's just having it's a little more cumbersome than just a chest x-ray, but a chest CT doing once a year to see that aorta is not growing in diameter. Once it starts dilating, it can be extremely dangerous because if it dilates too much, there's a very high risk of rupture Obviously, if that artery, the aorta, which is the main artery coming out of the heart, ruptures, that is not good. So I keep a close eye on those patients. Once a year, do a chest CT, make sure that the measurements are done appropriately, making sure that it's not growing. And once it's growing, you need to take action. At some point, you may need to decide that the time to do surgery in order to avoid the rupture is needed. So keep a close eye on that. You say it hasn't changed in 10 years. I presume that it's under good follow-up and they're doing regular CTs to see that it's not changing. I am old and I have vertigo that limits exercise. What can I do for exercise? So vertigo definitely can limit the way we exercise. How about stationary bikes? You know, doing things sitting on a stationary bike that doesn't require moving or cannot be dangerous. That's one of the options. Other option is to do exercises with the hands, just hand exercises, sitting on a chair and doing exercises with the hands, and that is definitely recommended. Also seeing a physiotherapist or cardiac rehab, things that are people that are experts in doing exercises. They understand the limitations of some of our patients, and then they can provide different options of exercise for patients that have different limitations. What is the difference between palpitations caused by bundle branch block and those caused by atrial fibrillation? Okay, palpitations can be caused by a number of things. But the most frequent is when we have extra beat. A lot of people, the majority of people, will have extra beats of the heart. That is a beat that comes a little earlier than that it should have come. And then you feel the next beat, that comes, it's going to be a little more powerful. So what we're feeling is that the heart that has time to fill up with more blood has a more powerful contraction, and we can feel it. And some people are very sensitive to these extra beats. The bundle branch block per se should not be causing palpitations. Atrial fibrillation should not be causing palpitations unless it's very fast. A lot of people that have atrial fibrillation did not even know, they're not even aware that they're having atrial fibrillation unless the heart rate goes very fast. In that case, they can feel that. Like I said, just to be clear about that, bundle branch block should not cause palpitations. Atrial fibrillation can cause palpitations, especially when the heart rate is too fast. And they are definitely not the same. So I think we went through most of the questions.
All right, perfect. If anybody has any other questions, you can email them to matherhospital@northwell.edu. Once you exit the webinar, you will see a link to complete a brief survey. If you could do that for us, it's extremely important and it helps us plan future programs. Thank you all again for joining today. If you want to see past webinars, you can visit our website, www.matherhospital.org/HealthyU. Thank you again, and thank you to Dr. Gruberg.
Thanks, everybody. Have a good afternoon.